grateful to share this space with 4 experts in the field who are committed to promoting the solution of opioid-related morbidity and mortality through data and research, policy change, and community programming. Starting from the end, we have our very own Dr. Amita Fakimi. Dr. Amita Fakimi is a clinical psychologist, the clinical supervisor for the opioid treatment program at Tarzana Treatment Centers. She has over 10 years of experience working with individuals, couples, and families. Dr. Fakimi has been working with persons struggling with substance use disorders in the field of addiction treatment for over a decade. She is specialized in the field of medications for addiction treatment and works with patients with opioid or alcohol use disorders at TTC. Dr. Fakimi is committed to providing a safe and supportive environment and hopes to be a vessel for change for her patients so that they can live happier and healthier lives. Thanks, guys. Next, we have Dr. Salazar, who is a Program Development and Contract Compliance Director here at Tarzana Treatment Centers, and also the COO of TTC College and co-founder. Dr. Salazar has worked in the field of public health since 1988 and has worked in the substance use disorder, HIV, AIDS, and mental health fields as everything from a counselor, health educator, community organizer, researcher, and administrator. He also oversees 2 narcotics treatment programs, or NTPs, and medications for addiction treatment programs that are designed for both adults and youth. So very happy to have him here and talk about his experience about developing and continuously improving the continuum of SUD treatment. Next, we have Dr. Brian Hurley, who is an addiction physician and medical director of the Division of Substance Abuse Prevention and Control in the LA County Department of Public Health. Dr. Hurley is the president-elect of the American Society of Addiction Medicine's Board of Directors. And he also chairs ASAM's Public Policy Coordinating Council and the 2021 Strategic Planning Task Force. I did not know that second part. That's very impressive. He also chairs the LA County SafeMed LA Medications for Addiction Treatment Action Teams and is the clinical director of the Addiction Treatment Starts Here programs through the Center of Care Innovations, which is focused on increasing the delivery of medications for addiction treatment in California's community health centers. Next, we have Dr. Eric Guerrero, who has a background, yes.
We almost didn't clap.
Dr. Eric Guerrero has a background in clinical psychology, social work, and organizational behavior. He completed his doctoral degree at the University of Chicago, where he received training in addiction health services research. As a clinician, Dr. Guerrero has provided psychotherapy to individuals and families for the last 23 years and is currently co-leading a national studies on gender and racial disparities in access to opioid treatment and the implementation of culturally responsive interventions. He is also leading multi-industry consortium to respond to public health crises, including the opioid and COVID-19 epidemics, and seemingly intractable impact of structural racism on vulnerable populations. All right. Okay. So first off, I want our audience members to become better acquainted with all of you. I know we kind of just went through the bios, but I don't think anybody in this room will disagree with me when I say that this is not an easy profession. And I think it is pretty easy to feel maybe defeated at times when we're just one person or one team working to address a plethora of public health problems and concerns. But one thing that I think that would be really valuable for our audience members and our students to learn is how you all found your start in the field of public health and SUD treatment. So what initially drew you in, and why have you stayed for as long as you have? I'll let anybody start first.
So good morning, everybody. This is Brian. I grew up not far from here. I was born in Canoga Park, and I went to Van Nuys High School. And And that was around the time that methamphetamine was really taking hold. It was in the 1990s, and still hasn't gone away. But it struck me, looking at the lives of people I knew who had been impacted by substance use, that we as a community and as a healthcare system could do better. And so I applied to medical school, saying I want to go to medical school to be an addiction physician, which at the time was not common. Addiction medicine was not a board certification, and now it is. But it occurred that we could do a lot better in our healthcare system for making addiction treatments available to the people who need them, and making the right treatments available at the right time for the right people. And that project has not ended. That continues, and that continues to keep me engaged and involved in helping solve problems in our community.
Thank you.
So similar to Brian, I also grew up in the San Fernando Valley, specifically in Sun Valley. Big shout out to Polytechnic High School. That was my high school over on Roscoe and Arleta, I believe. The way I entered into alcohol drug treatment services was really through the public health realm. I was always very interested in addressing health issues, and my first job was as an HIV/AIDS health educator. And one of the things that I quickly encountered is the amount of HIV infections that were being driven by alcohol and drug use. So substances that led to risky sexual behavior, or direct infection through injection drug use. The reason that I stayed, meaning I entered the field in 1988, the reason I stay is because even if it's just one life that we can save from getting an infection like HIV and AIDS, or having to deal with the negative consequences of alcohol drug use, I think it's worth it. And in terms of the people that I work with, including the folks that are part of this panel, that also energizes me. The fact that they continue to be committed in doing the good fight.
I just want to say, first of all, just thank you so much for this invitation. It's certainly an honor and a privilege to share this panel, to be with this panel today and with all of you. Just very few times that we have this opportunity to share among professionals. As you know, substance abuse is a very intimate field because it is very personal. It's not a profession that you just pick to make money or to get a single source of gratification. That it really it is a whole person. And with that, my story is probably similar to many of you, where you enter the field very early, 3, 5 years old, when you start witnessing, substance use in the family, in the friends. And within that, you start being affected positively and negatively, and really engaging with the field in one way or another. And that was my story, and that's the story of many. And as I moved in to try to contribute, found my way in psychology, completed a master's in psychology, focused on treatment, and then later really wanted to do something bigger with organizations and policies. And that's how I got my PhD, to be able to look at systems, not only at treatment families, but also to affect systems of care and improve quality for many, especially access to care. And it's very personal because also family members have been highly affected and continue being affected. And that's what really has encouraged me to continue more and more as I see family and friends continue this struggle. I recommit every time.
Thank you. Happy to help you there. Dr. Fakimi. My name is Anita Fakimi, and I'm very, very happy to be here. I really appreciate the invitation. It's an honor to be a part of this panel, sitting here with you guys. I started 21 years ago, working with SUD population as a part of my practicum in graduate school. I recall one of my professors telling us, you really need to look at what population you want to work with, because we had to do rounds and trainings. And I remember she said, look for what scares you the most.
Mm.
And I went back home and I was having a conversation with my mom, like, what do you think? You know, I'm you know, a little TMI, but nothing really scares me. And I thought about stigma. The first thing that came to my mind was, what is everyone else scared of? And the prison population, the addiction population were the first things that came to my mind. And I immediately started looking up, you know, clinical training opportunities around, and got my foot in the door with Phoenix House in Orange County.
Yeah.
And within the first week, I remember, you know, one of my very first patients was this big man, you know, tatted up everywhere, crying in my office. And I was like, this is it. Like, this is my niche. And it has kept me going this whole time.
I love that. Yeah, absolutely. Do what scares you, and the rest is that how that quote goes? I don't know. So I do want to talk about the opioid epidemic, just pull some of our most recent data. And I was doing a little bit of math yesterday, trying to figure out how much this has increased since the last time I did this math. So from April 2020 to April 2021, there were about 75,000 opioid-related deaths in the US. So when I was doing the math, that was about one person dying every 7 minutes, and just in the US. And I remember probably 3 months ago, 4 months, maybe it was a year ago, I have no idea. Months kind of bleed together, but I used to report one person dying every 11 minutes. So that was pretty jarring to me. And if any of you can give us a quick history of some of the events that have transpired over the last 20, 30 years that got us to this point where 75,000 people are losing their life from an opioid overdose every year, I think that would help our audience understand kind of the scope of the problem and how we got to this point.
Silence.
I can go. I think if you think about, you know, 20 to 30 years ago, about where doctors were, you know, being told that this patient is in pain and you have to treat it better. You have to pay more attention at what you do for this patient. And probably Dr. Hurley can attest to the big push for pharmaceuticals to just flood the doctor's offices with, here, talk about Purdue Pharmaceuticals, to try to push for opioids to be the treatment for patients, to treat their pain. And here we are, you know, 20 something years later, dealing with the problems that, you know, led after that, learning post what it means to struggle with OUD. Where I would say it started.
So, substance use tends to go in cycles. There was a cannabis cycle started in the 60s, a cocaine cycle started in the 80s, methamphetamine started in the 90s, but also in the 90s was when, as you said, we saw huge numbers of prescription narcotics be available dominantly, although not exclusively, through medical settings. That actually cycle is on the downturn. Opioid prescribing has been down since 2011. But when opioid prescribing went down, heroin went up, And now we are in a fentanyl cycle. And what makes fentanyl so different from other cycles is its potency and the overdose risks. Substance use does go in cycles. I imagine that fentanyl will begin to have its own descent, but we're not there yet. And it'll likely be multifactorial around other substances hitting the marketplace, around treatment being available. You know, there will be a number of factors that would likely contribute to that descent. But that's how we ended up where we are now. I think the CDC actually is now published we're at 100,000 deaths a year. It is only getting worse at this point in our. I say this from a public health perspective on its trajectory.
Right. I just would like to add some opinion mixed with some statistics. Some of the nuance of this certainly is that pain has always been there and in the nation. The nation has struggled through pain through centuries. It is how the nation responds to pain and drug markets. What drugs are released in certain environments? And one very characteristic release were maybe in the 70s around urban environments, low-income urban environments with heroin. And then that has been shifted in how some of pharmaceuticals took on that later in the 90s was to legitimize the use of OxyContin and others. So again, that there's this fine kind of more nuanced notion of how drugs are released into certain environments, and that how some of those, like more of the prescribed drugs, have been hitting some of the suburban, some of the Northwest, some areas that in essence have also contributed to where we are now, with some street markets now being flooded with fentanyl. But all in all, is some of this drug market, what's available on the street, what's available in doctors, dentists, all these different professionals, what's available for them to treat pain. And I think that's where we are now with this massive influx of different options for treating pain without really thinking about the responses and interventions.
What I really appreciate about the panelists is, and what you're sharing is the fact that as the direct service provider, we might only see that one individual that's impacted by addiction. But what the panelists and I would also support is the fact how complex that particular outcome is, and that there's these very significant structural, environmental things that are occurring in our society that are contributing to that. So while as direct service providers, we just see that particular individual, there's this whole structure behind that has to go part and parcel with the work that we're doing at the individual level. And I think that that's where the public health model can really come in and help us, aid us in potentially finding solutions for those individuals that might be impacted by an opioid addiction.
And I think that, you know, there's been a lot of, especially within the last couple of years, there's been a lot of discussion about organizations adopting cultural competency or cultural humility through training and things like that. What does that look like for Tarzana treatment centers?
Well, you know, I think what that looks like for Tarzana treatment centers or any other provider organization is making a commitment to actually use that as a lens for program design, for policy development, and for implementation of services. A lot of times that lens also has to be supported by our ability to collect accurate data of the work that we're doing and the work that we're implementing in our various communities. Not all communities are equally benefiting from our medications for addiction treatment service delivery, and not all of our communities are equally being impacted by the negative aspects of opiate addiction. And one only has to look at certain specific communities, like those that are formerly incarcerated or reentering into our communities, or presently, particularly in LA County, our homeless patient population. And so, through partnerships with institutions like the ones that Eric runs, I think we can better have access to data, relying on county level data as a way of helping guide and orient our services so that we can be effective with different communities that make part of our fabric.
And Dr. Guerrero, you conducted quite a few studies that examine gender and racial disparities in access to IUD treatment. And you indicated that mounting research suggests that SUD treatment programs that have a focus on cultural competency and humility among staff and treatment policies and treatment practices, like Dr. Salazar is discussing, are associated with improved access and longer retention among specifically Latinx and African American patients. From your experience, what areas and needs do we need to prioritize in order to eliminate barriers to care for our Latinx and African American patients?
Yeah, thank you, Megan. Well, first of all, let me say that Tarzana is such an exemplar. It's an exemplar in the treatment field in terms of investing in culturally responsive care. Just to give you some stats, we've run national surveys, and we're running one right now, actually, but we've run it over the past 15 years. We've collected everything from the primary survey information to interviews across the country, and as well as focusing on LA County in particular, because LA County is so big, that it kind of reflects the nation in a way in terms of number of treatment providers and diversity of them. But basically, the average treatment program is actually pretty small. It's about 3 to 5 people, the average treatment program. And then, of course, that doesn't compare to Tarzana. The average treatment center has about 25% African American staff and about 18% Latino staff. When the populations generally are about 35 to 40% African American, about 25% Latino. So actually, there's more African Americans and Latinos in the treatment system in the country than, of course, that staff that reflects, reflects their race and ethnicity. A lot of treatment programs say that they are culturally responsive, but then when you look at very specific things such as representation, or you look at language consistency, that's when you start seeing really uneven numbers. So the basics are certainly representation. Be able to not only the representation of those who are served, but also understanding of their cultural view, their worldview, right? Because certainly there's diversity within our populations, our subpopulation. So understanding that cultural view is critical. One of the major indicators, I think, of engagement, and that is when the client says, I'm going to come back. I like my counselor. Generally is actually that worldview. Certainly African Americans in our data tend to be more likely to want an African American counselor. Latinos also, but a little bit less. Of course, with Latinos and Spanish speaking, that is a must, right? It's necessary. You'll be surprised how many programs across the nation, they say they're culture responsive, Spanish speaking, but then clients, primarily Spanish speaking, end up in groups that are English only, or that are a mix, where the counselor doesn't speak English fluently. Maybe it's Latino, but doesn't speak English fluently. So there's a gap there. So that's when you start seeing some challenges with basic understanding of concepts. And of course, if I don't understand the concept, then it's hard to kind of get the cultural nuance. People to understand where I'm coming from. The little town in Mexico that I'm coming from, and how I used to drink with my family, and how drinking was wonderful. But then at one point, I immigrated and I end up, living with 5 men. They all drank, and then I drank, and then I developed this addiction to alcohol, and then later heroin. Those nuances of where you're coming from and how to understand it in the language that you feel most comfortable. That certainly has been the challenge for the treatment system. I just want to emphasize Tarzana and through Dr. Salazar's investment certainly understands that, and it's kind of building. And nothing is perfect, but certainly those indicators, those basic indicators are critical. Representation from management all the way to the counselors and coordinators, language, certainly the connection through those, and sharing worldview. I think those pieces in different measures have been associated with higher retention and higher lower wait time in men's retreat.
Right. And, I want to touch on this point that you brought up when you mentioned that there are a lot of underserved populations who may not engage in counseling as much for a number of reasons because of representation that is so huge. But a lot of individuals do not understand the value of counseling and behavioral therapies in substance use disorder treatment. And I think, as healthcare professionals, we can kind of understand it. But what is the role of counseling and other behavioral therapies as it relates to medications for addiction treatment?
Thank you.
Dr. Fakimi.
So as you were speaking, Dr. Guerrero, I was thinking I sit here representing 8 counselors, 6 in Tarzana, 2 in Palmdale, in addition to a few other staff, 4 nurses, and 2 supervisors. That's my clinical team. And I think the importance of being able to onboard a counselor who not only has the proper education, but is able to create a connection with their patient through compassion, through meeting their patient where they're at, not sitting there and telling them how it's going to be and how you are going to do this versus where are you? What can I do to help you get through this? Because I always think the best combination, and almost in any disease, but specifically for addictions treatment, is behavior and medication together. Because one without the other is just a crutch, right? One without the other is not as effective, because our patient population also needs to understand how to sometimes relive life, like how to learn how to do the most basic things. If you have a patient that's getting released from prison after 10, 15, 20 years, they don't know how to function in society. They know they'll need methadone or Suboxone, but they don't know how to function in society. And to kind of rebuild that connection through a counselor, it is just as important as the medication in my view. And I don't know if I directly answered your question, but the piece of the counseling that we try to practice a lot is motivational interviewing, which the basics of it is, where in your recovery are you at? And the spectrum is very wide. So anywhere on that spectrum that the counselors assess with the patient that I'm ready to meet you where you are. If you're at point A, great. If you're at point C, great. There's zero judgment that goes into that, and we'll just help you move one step at a time forward.
And I think when we touched on the counseling, I want to touch on the other very important aspect of MAT, which is the medications. So, when we see somebody who is in the throes of addiction, we might see some pretty kind of alarming or out of character behavior. So it could be things like stealing from family members or pawning items or doing other things that might be risky or hazardous, might jeopardize their health and well-being. But what I want to point out is the fact, or the correlation, that I don't think a lot of people fully understand, but the bigger their craving, the bigger risk they are willing to take in order to get rid of that craving. So for patients with an opioid use disorder, I think it's very important for our audience members to know that their behavior can be kind of defined based on the severity of their craving. But most importantly, we know that we have medications that can completely erase those cravings, or at least minimize those cravings that cause that kind of destructive behavior. So Dr. Hurley, I'm hoping you can tell us a little bit more about those medications.
Well, sure. So if we're talking about opioid use disorder, we should be specific. There's 3 FDA-approved medications: methadone, buprenorphine, and extended release naltrexone injection. Those are the 3 that seem to work. We should talk about what the medications do. They help keep people out of withdrawal, particularly methadone and buprenorphine. They are used for something called withdrawal management. One of the reasons people oftentimes resort to stealing is they are really afraid of getting sick. Those medications keep you from getting sick, or dope sick, or opioid withdrawal syndrome would be the diagnosis of that. They also help reduce or eliminate cravings, depending on the person and depending on what they're craving. They help reduce or eliminate opioid use. No, not everyone that takes methadone or buprenorphine or extended release naltrexone injection stops using altogether, but that depends on kind of where they're at in their recovery. And the other thing that we aim for is not a ton of side effects, because you can find the dose that works for somebody to help with their craving, help keep them out of withdrawal, where they're not feeling clouded, where they're not feeling low energy, where they're able to like go out and live their lives. So that's what we're aiming for. And that's what the medications do. And for opioid addiction in particular, the medications work really, really well. Like 50% response rate, which is a really high response rate compared to a lot of other medications that we use. And so, the number needed to treat is not that high to see a big clinical response for the opioid addiction medications. What the medications don't do is help people get their family back, or get a job, or get housed, or resolve their legal case. Now, the fact that they're not in withdrawal may be all the help that they need, right? Like, I'm not of the opinion that every single person that takes medication definitely needs counseling. But more often than not, people will benefit from learning the skills to navigate the internal triggers for relapse. So, and if you've heard of hungry, angry, lonely, tired, the major internal triggers for relapse, like the medications help with that, but so does counseling. And then I actually, in my model, I have meds and counseling, and then there's a third arm of the triangle: support. Support is everything else. Are you housed? Are you employed? Do you have transportation? Counseling can help link people to that. Case managers can link people to that, but it's ultimately up to somebody in their milieu, and in order to be able to get there. Social determinants of health would be the term that we use to help address wellness, and that sort of in the addiction treatment field goes to people, places, and things. Where are you hanging out? With whom? What are you doing? Counseling doesn't necessarily dictate that, right? Like that is very socially determined. Now, I want all of my patients to have everything on the menu: meds and counseling and support. But I'll editorialize here for a second. Historically, when we give people addiction treatment, we admit them, then we do a comprehensive psychosocial assessment, and then maybe, if they're lucky, at some point in the future, maybe, if the appointments work out and they're still in treatment, they might see somebody that could prescribe them a medication for addiction treatment, maybe. And I would say, actually, I would propose, and now I'm working with Kennedy Department of Public Health, working on trying to operationalize doing what I call a med-first approach. If the thing that is most distressing is withdrawal, and the thing that's going to interfere with somebody's recovery is cravings, then start with the medications, and then layer on counseling when somebody is sort of ready to do counseling. So it isn't that I'm a med only sort of advocate. I'm a med first advocate because the medications have such a strong effect on helping stabilizing behavior so quickly that becomes a foundation to layer on counseling support when somebody's ready. But there are patients that I treat with medications only that have decided not to do support. And I will pretty much only do that as long as it's clear the medications are helping them. But I'll continue to treat them as long as the medications are helping them. And that means it's not just been 30 days, time to come off, been 60 days, time to come off, 6 months, a year. Like, I'm sometimes asked, how long should a patient be on a medication for opioid use disorder? No, as long as it's necessary. And that might be their whole lives, right? I don't want anyone on a med for longer than necessary. I don't want people with diabetes to be on insulin a moment longer than they need to, but not everyone diets and exercises their way to a healthy blood sugar level, right? Some people need to be on these medications, and I make no moral judgments about that.
That's a really important point that Brian is making. In the past, we would say, the Cadillac program, but I guess most of the audience members probably wouldn't understand that reference. So maybe the Tesla would be the equivalent. The Tesla model of the program ideally would be the combination of the behavioral support along with the medication. But certainly, using clinical assessment tools that are available to us, if the primary issue for the patient is addressing their fear or concern about withdrawal symptoms, perfectly fine that we start off with just the medications. Now, part of the problem that we have is that the level of the interventionists that we need for that are physicians and mid-level people willing to be part of the system and be willing to provide that prescription. So we're very fortunate that we have folks like Brian that are part of that system of care and see this as part of their responsibility, part of their commitment in the service delivery system. Unfortunately, we do have a lot of physicians today who are eligible to perhaps make this medication available to more of our communities, more of our patients that need it. But unfortunately, it's not happening, or it's not happening in all the communities that we need that access to occur. So in part, it is the patient, but I think in part is how our communities are set up and where patients can actually access these needed services.
I just wanted to add a nuance to this conversation. I totally agree with what has been said. This notion is problematizing the fragmentation of the treatment system, right? The fragmentation in the sense that it is a structure sometimes if it's a criminal justice system, if the client's in the criminal justice system, there might be kind of a fast route to get one type of service, right? But not the other. That is, they may get medication, but they don't get the counseling in the county. Or they may get community-based counseling, but that treatment provider doesn't provide medication.
There's no prescriber, right?
Right, there's no prescriber. So that's one issue. The other issue is an area that we're seeing more and more that it's creating these huge disparities is what we are referring as the bifurcated treatment system. And a bifurcated that is bifurcated by race, insurance, and socioeconomic status. And this is more and more throughout the nation. We're seeing basically minority folks, and if an individual is suffering from opioid use disorder and it's a minority individual, it's most likely that they're funneled into a treatment system that delivers methadone. If that individual is white, it's most likely that it ends up in a treatment system that delivers buprenorphine. So that you can see throughout the nation. And what does that tell us? That the structure of the system is creating options where you end up with limited choices, right? Especially for low-income minority individuals, they may want to benefit from buprenorphine, but they are not likely to get it because that buprenorphine tends to be more prescribed be available, I guess, by individual physician providers, office-based provision, or maybe maybe treatment centers that are a little bit bigger and that they are far away from their communities. So you start seeing some of the distribution of treatment providers and those that provide buprenorphine, they're farther away. We have a paper that actually shows it's farther away from minority communities. And this is not only in LA County, which is highly diverse, but it's actually across the country. So, and then if you have Medicaid, you end up in some area with in your minority with methadone. And if you have private insurance, you're more likely to get to a provider that is provider of buprenorphine. So again, this creates quality of care concerns, right? Especially for minority communities.
Can I just add to lack of providers? I think a big struggle that probably everyone is dealing with. One of our providers was talking to me about the lack of education for medical students while they're in medical school on addictions treatment. You know, our current provider, you know, a little later in his life, he went back, got his specialty addictions treatment, and he was telling me, he's like, this should be a third-year round for every medical student to familiarize them with addictions treatment. Why is it that we learn about how to treat the diseases that are caused by addiction versus prevention? Learning it early on, so and not only just to learn how to treat this population, but to attract some more medical providers to this field. And, you know, not at all to put the responsibility out there on them, but I think as a whole, we need to look at, you know, take a step back and look at how systems of education are set up. That goes for medical providers. It goes for my own field of psychology, where, you know, you have to relearn things after school. We should be taught these things in school. Education systems really need to change and look at current training. We need current stuff. We don't need to learn what was published in 1956. I mean, no offense to that research, but really 1956 has nothing to do with 2020, or in our case, almost 2022. We need current training, current scientific data to guide what professionals learn in school, what college students learn in school, what kids learn in high school, and all the way back to kindergarten. I have a 6-year-old in kindergarten right now. I look at what he learns. Is it current? Is it new? Is it applicable to you right now?
Yeah, and fortunately, we do have institutions like SAPC, TTC, and the broader SUD network that are relying on principles like whole person care and integrated care and no wrong door to access, you know, that hopefully will allow us to make a broader, bigger impact on those that actually need these SUD services.
And I wanted to put Brian on the spot as the
Sure.
president of ASAM.
President-elect.
President-elect. The largest medicine, addiction medicine organization in the country.
Sure.
Tell us something about physician education.
Well, it's easy to say an undergraduate medical student, that's somebody who's not a resident yet, is not finished med school. An undergraduate medical student should get some coursework. Most medical schools teach like an hour on addiction. I mean, one can argue about the adequacy of that hour. But I would also say, as somebody who went to medical school to do addiction medicine, I don't think an hour of like the ventral tegmental dopamine circuit really impacts my clinical practice. A rotation in third year would be better, but frankly, how many communities have sites where you have a physician preceptor, right? Where you have to have somebody now sign off on that somebody did what they're supposed to do in the rotation. And most addiction treatment programs are not run by physicians, so it makes it harder. It's not impossible, but it makes it harder to have a functional clerkship. And then how do you, in your internal medicine, family medicine, psychiatry, pediatrics, whatever, pick your residency program, which is really where people learn how to practice, is in their residencies, not so much medical school. That becomes a much more challenging problem. I can get, ASAM has an hour on like what medical schools need to know about addiction, but that's not going to change practice. What's going to change practice is, in other words, our treatment systems inform what people learn, and it's reinforcing. So if our treatment systems say addiction is not treated in hospitals, it's not treated in primary care, you have to send somebody off to a special network where there's no doctors, but where there's not a ton of doctors, it reinforces this model that if I want to be an internal medicine doctor, I don't do addiction. If I want to be a family medicine doctor, I don't do addiction. So we need both curriculum development, but then also the development of good clinical programs that people can learn from. And the last thing from ASAM's perspective is ASAM is very aggressively trying to put out, we've got a e-learning center, we've got a bunch of in-person, we're one of the first societies that have put back, sort of in-person training again. We're really trying to get education out to as many people as possible, and are thinking very broadly about physician education, non-physician education. How can we make sure that these messages get out to as wide a group as possible, but that doesn't undo a lot of the dynamics within our treatment system that impact clinical practice.
So we've talked about a few barriers to accessing treatment. I also want to talk about some barriers to implementing MAP programs, on the county level, community-based organization level. Can you tell us a little bit about that? There's a lot of red tape.
It's interesting because I have this idea that medications for opioid use disorder need to be available everywhere. In other words, we think of medications for addiction treatment as being an addiction service, but they're not. Well, they are, but they're also an emergency medicine service, and a hospital service, and a street medicine service, and a mental health service, and an addiction treatment service as well. And so when I first started working in the county, I did not work for the Department of Public Health. My first job was the Department of Mental Health. And one of the things I ran into, and I'm so glad for my colleague, Jeremy Martinez, who is currently a medical director for co-occurring disorders for DMH, who I think has operationalized this much more effectively than I was able to. We ran into the system saying, this isn't mental health, so we're not going to pay for it. And I'm saying, no, medications for addiction treatment are going to help somebody who's recovered from schizophrenia or depression or bipolar disorder, whatever. Ironically, we've had some of the biggest growth with medications for addiction treatment in hospitals, because that's where doctors are, generally speaking, right? There isn't this question of, are you approved to do medical services? It's like, yeah, of course. And so if all I need to do then is train people on how to identify opioid use disorder and treat it with medications, that's not to say patients don't need other things, but I can get a medication for opioid use disorder program built in the hospital. In primary care, it gets a little more tricky. Primary care doctors tend to be more reticent about taking on more work, because a lot of areas of the healthcare system are pushing primary care doctors to do more things in general. So primary care doctors have overall, I think, been less aggressive about taking on medications for opioid use disorder, but there are certainly examples here in LA County of a whole lot of primary care clinics that now have MAP programs. And the functional MAP programs, it has a prescriber, but it has a social worker, right? It has a community health worker or a peer advocate that can help with a lot of the counseling and support that people need to be successful. And then in addiction treatment, I think, to your point, Dr. Salazar, we see a real dearth of prescribing clinicians available to jump in. And that's where I see a big bottleneck in the SAPC system of care, is we don't have enough prescribing clinicians to really meet the need at this point.
Yeah, I wanted to add, first of all, wonderful to have Dr. Hurley here to tell you exactly what's going on at the county level, the policies. And my job is to add more nuance to what's happening in the psychological state of the system. So we ran this study at LA County Department of LA County, the emergency department. One of the probably one of the most robust findings that we've learned in terms of engaging people that have an opioid use disorder or that had, overuse and they ended up in the emergency department is medication first, right? In Boston, they run some of this work. Dr. Nofrio has repeated those trials and certainly engaging
In Connecticut.
and in Connecticut.
Mhm.
Engaging, because it was out of
Yeah.
Yale University, but they started in Bernstein in Boston, of course, and Boston a medical center.
Mhm.
So basically, even those individuals that come with an opioid use disorder related issue, injury or related issue, and it started them in MAT right away, mainly buprenorphine, they certainly engage faster and they stay in treatment. So it was a pathway to treatment, a good pathway to treatment. So so I'm glad that is brought here. But when we did this study here in LA County, we found that basically some of the issues that they have been raised, which are one is that physicians lack of addiction science knowledge, right? So generally they would treat somebody comes in with an injury, physical injury. They will treat their physical injury and would not pay attention to the fact that this person was high on opioids, right? And so then the opioid use disorder doesn't get to be channeled or paid attention to, and then this person goes and then comes back with an overdose later. So that was one issue that we identified. Second is that there's stigma and biases, right? And especially with minority populations, where doctors, use the understanding of pain levels, right? If it was a minority African American, and this is actually reflected in the literature as well, that the pain levels are undervalued or not believed as much as if it was for a member of a Caucasian or white race. So certainly bias in assessment in prescription certainly plays out here and played how, or at least was reported by the same physicians and nurses as playing a role. The other is the criminalization of the homeless and the bias towards low-income individuals. Because there's this substance abuse person I don't want to deal with. It's kind of more seen as a nuisance rather than a person that really needs immediate support. And I can understand that because physicians and nurses agreed that it was too overwhelming. They didn't have the resources. And also they complained that the treatment systems were unreliable. So if they try to make the link, they typically didn't get a call back. They didn't get a response right away. So certainly, again, I emphasize the system fragmentation here. But certainly areas and avenues that I know that SAPC is identifying and that some of the Department of Health and Human Services are also identifying that need a lot more tightening up.
Megan, I'm sorry. The only other point I would add to everything that's already been shared is I think workforce development. Because our field employs so many people that identify as being from the community, and depending on how we came through our own early or long-term recovery, we may have come through a model that either at that point did not have these wonderful medications available, or actually proactively discourage the use of medications in combination with the behavioral health interventions. And so I think workforce development and training, and I think that's one of the great things about Tarzana Treatment Centers College in terms of having that emphasis and including that medications for addiction treatment as part and parcel of what the future SUD certified counselors are getting in terms of normalizing and advocating for the inclusion of this tool in our toolbox this is an amazing development that we have these 3 FDA-approved medications that can help us be more successful in the work that we're doing. But yet, at the frontline level, there's still a lot of stigma and misinformation in our workforce about the use of medications in this work that we're doing.
Yeah, I would also add that a lot of stigma surrounding these medications come from the rest of the therapeutic community, unfortunately. We've had maintenance clients who have stopped coming into Medicaid because their peers and groups said that they're not really clean, and they were just treating one addiction for another.
Clean.
And
Clean.
yes, exactly. Oops, sorry. And I think that that's something I've had to dispel pretty much during every single group I've done for patients in withdrawal management. When we're doing MAT education groups, there's always one patient, at least one patient, that brings that up. And sometimes it's a little hard to wrap your head around it and try and figure out how to dispel that myth. When you're new to the SUG workforce. So I want to ask you, what's misleading about that sentence, that MAT trades one addiction for another? And how should we respond to it next time we hear it? And while you guys think about that, I'm going to collect questions, and we'll go through our Q&A section in a minute.
I can try to address that clinically because I think there's a big medical portion to it, which is not my forte. We have experts here for that. I think clinically, if you think about how change is created, it is probably dissemination of accurate current information that changes and shifts a culture, right? And if you think about the culture of sobriety, clean, dirty, these words have impacts on patients. So to start, we have to change the way we talk. We have to teach new and change substitute the words out for patients that have been part of a system for so long. These are, in my field, we call them cognitive distortions. What are cognitive distortions? Just think about distorted thoughts that over and over and over get reinforced through what has been a support system in the addiction field, which is, AAs, NAs, all those support systems, which are wonderful. But to add and create some progression in those systems and fields, and a lot of that, Megan, you mentioned earlier, therapeutic systems need to change. Our own colleagues need to educate and re-educate and stay current with the times. And, being able to challenge rigid thinking is a first step in changing a culture. Having a trusted leader disseminate that information to change that culture is key. And with that, I go to the leaders.
I think you're right about leadership support, by the way. One of the things that leaders in the addiction treatment program can do is start by updating our language in exactly what you described. Right? So I don't describe addiction in terms of clean or dirty because those aren't clinical terms. I describe things in terms of remission. Right? The person has an active substance use or substance use other than remission. The word recovery is always sort of this middle ground because it can be used clinically, but it's also oftentimes used not clinically. But I don't generally use the term sober with patients unless they explain to me what they mean by that, because that could mean different things for different people. I can't tell you how many people that tell me they're sober and yet they smoke cigarettes. Is that sober? Is it not sober? Well, depends on who you're talking to, right? So this is there's sort of some nuance to this. It's funny that I'll bring this up, but I like to go back to original texts such as the Big Book of Alcoholics Anonymous. What does Bill Wilson and Dr. Bob say about medications. They say members of 12-step or if Alcoholics Anonymous should not be giving medical advice to each other.
Hmm.
That's what they say. They don't take a position for medications, against medications. That's a decision somebody makes with their doctor. And so when I run groups and a group member says, well, my feeling is da-da-da-da, I'm like, okay, appreciate your feeling about your care, but you don't get to tell other people about their care, right? And if they're getting a medication, unless it's a medication group, generally speaking, the medication visit happens outside of that group format. And I can tell you my own patients, they get these messages, and it's from groups that they're in, it's from sober livings that they're in, it's from other sort of settings of care or support. And I encourage them not to be discouraged from people that really are commenting on things that's none of their business.
I wanted to add the issue of how do we conceptualize progress? How do we conceptualize success? From a treatment system, progress may be the number of treatment sessions that you show up to, right? And how Medicaid may pay for it, how many the county will say, yes, this person is making progress, showing up.
Treatment retention.
Right, retention. There's also treatment completion, even in opioid use disorder, that we know it's maintenance, that yet we say, well, if they meet these standards from the treatment plan, they may complete a treatment episode. So there's that. The interesting thing here, we just came across some findings that are a little puzzling, especially for LA County, which when we compare individuals or methadone, because as you know, people here in the county, as in many places in other counties, other states, they may have opioid use disorder, but they end up in treatment programs that don't provide any medication-assisted treatment, it's just counseling, right? Interestingly, you would think, well, those who provide medication-assisted treatment probably do better. Well, in the county, they don't. There is a portion of individuals just receiving counseling that actually report completing treatment more than some in methadone. Now, that's very puzzling, right? Because then we're all talking about how good medication-assisted treatment is. We believe it's not the medication. We believe is the methadone treatment system. How that treatment is structured. Typically, it's very rigid, right? As you know. So it creates a lot of barriers to engage. So it's not actually taking a medication, it's actually getting to treatment in the morning.
You're looking at a system effect, not a medication effect.
Exactly. Yeah. So that will be my takeaway. Thank you, Brian.
What he said.
Really great segue to one of our audience members said, with the easing of restrictions around methadone prescribing during the COVID-19 pandemic. So now, for example, we're able to offer 14-day take-homes for patients with methadone, which has never been done before, really.
Well, we would for patients who earned their way up to that amount. Or we wouldn't do it this early in treatment.
Right. And for those of you who don't know, methadone is probably the most highly regulated medication in the U.S. So during the COVID-19 pandemic, we were able to, ease off these very, very strict prescribing practices. So how has this had an impact on retaining patients in treatment?
Retention?
Yes.
I actually wanted to bring up this point, so I really appreciate this question because I think there are important people here that could try to advocate for a continuance of those ease restrictions. It was wonderful.
Yeah.
It was wonderful. It is wonderful.
It is wonderful.
It is wonderful. It is probably what should have been done. Speaking of, I kind of want to go back to my own point about, be progressive in looking at systems in looking at how we provide treatment. We talk about we want our society to get better, but we put all these barriers in place so they can't get there or they have to jump through hoops. And so for a lot of our patients, at the time, I think everyone was just so scared of what COVID could do. And luckily, Tarzana was able to implement ways to use the eased up restrictions to make it even easier for patients to get access to their medication. And I recall a conversation with you, Dr. Salazar, about, other departments are seeing, numbers drop. How come OTPs are still, all your patients are still coming? And I said, because we ease restrictions. If a patient has things they've been exposed to someone with COVID, they can show up at curbside and get their medication and go. And they don't have to be scared about what that could mean for them and for their family. And so to think about when a policy really impacts a patient and the rest of their community, this would be the topic to discuss.
And Amita, the other thing I would add to that is, I think patient education about the diversity of medications that are available also helps ease access issues. So we primarily run an NTP, but the bulk of the medication that we're using is actually buprenorphine.
Mm-hmm.
It's not methadone. But part of what we do take to heart is doing patient education up front in terms of this is the menu of different medications available to you. And we are finding that based on that education, patient choice at times is methadone, but increasingly it's actually buprenorphine. And so having systems that can work with that and allow for that, I think going forward will further contribute to hopefully better access for our patients who need these medications.
Mm-hmm. And to kind of think about now those eased up restrictions are kind of going to slowly probably go away. And we're going to go back to 2 years ago again. We're going to regress instead of progress.
SAMHSA is looking at it. SAMHSA's not. SAMHSA's
Okay.
not. I don't work at SAMHSA, so I can't. I cannot take responsibility, but I do know they're looking at continuing some flexibility.
Yeah, I was just going to say to think about having to communicate that to a patient that, oh, the thing that was working really well for you, sorry, take it up with them. That's the part where I think we struggle a little bit. But to Dr. Hurley's point, these are, phases that a patient can get to have take home.
Yeah, and I just wanted to add, just kind of add a little bit of controversy to this conversation.
We love it. Yes, bring it.
The structural racism.
Mhm.
So how come a system that we know, methadone treatment that we know targets minority communities primarily, right? How come that is highly regulated? How come methadone is so regulated when you take it, how much, and buprenorphine? So they regulate it. We actually want more physicians to, they go through some pretty short training and then you're waived and you prescribe buprenorphine. You just need to have private insurance or sometimes Medicaid, I think, is going in there gradually. But that's what we see, this bifurcated system. And that is clearly and more emphasized by race, ethnicity, insurance. Insurance is highly correlated with race and ethnicity, right? Medicaid versus private. So that kind of creates a lot of different barriers to get the kind of medication you need. And one issue that we've been pushing forward at the federal level, at least community-based research organizations, is investing in methadone as extended release, investing in the technology for methadone, because actually methadone is not bad. Methadone it is comparable to buprenorphine. It's just that it has been stigmatized as the the drug treatment for minorities, right? They say the drug for the ghetto. So, so we need to change that. We need to kind of improve because it actually works. We need to change the narrative. We need to have extended release, all kinds of options, deregulate. So it's available in pharmacies everywhere. And that's where I think, from a policy perspective, I think where you can actually treat individuals equally, regardless of race, ethnicity, and private choice.
And I think you started out, did I cut anybody off? I'm sorry, okay. I think you started responding to this next question that I was gonna ask, so thank you. But another one of our audience members asked, what resources are being allocated to ensure that MAP services are available and known to Black and Brown people in underserved communities of color? So, you know, I think that there's a lot being done with the county. There are a lot of, you know, low threshold buprenorphine projects. There are also a lot of programs that are being implemented within T2C. So I'm hoping you guys can tell us a little bit about that so that we can then tell all of our patients about that next time they're in need of services.
So probably the most comprehensive resource right now that's run through the county is Recover LA. RecoverLA.org is the name of the site that has a whole list of resources, specifically including medications for addiction treatment. There is a medications for addiction treatment specific site called matworks.org that LA County stood up, specifically to try to make sure that Medi-Cal beneficiaries and people without insurance were aware of what options existed here in LA. And then I used to work for a different county department, and that county department this January is going to Los Angeles MAT.org. That is a site where people can read more about what medications are, for addiction treatment are available through community health centers that aren't through the drug Medi-Cal network that SAPC operates, because there's a non-trivial number of places where you can access medications for addiction treatment outside of formal addiction treatment. So those would be the three big resources that SAPC has promoted. I'll just editorialize. If SAPC had, you know, $100 million marketing budget, we would be able to get the word out more, but we don't. You know, the more resources we have to get the word out, the better. And particularly in, there's a lot of, it's sort of I don't want to say crowded field, but there's a number of different entities that are community health focused. And I think sometimes the addiction treatment messaging doesn't always break through. Yeah. We'd like it to, but I just want to acknowledge it's not always as visible as we want it to be.
And I just want to add to anybody that hasn't checked out Recover LA, it's a really, really great resource for us as providers and especially for our patients. So, you know, it's mobile friendly. We love it. It's a lot of tips on how to begin treatment, how to start asking for treatment, what's available, how to address stigmas. It really covers everything. So,
Megan, I would add to Brian's. I think that the two big changes that could really help us address a lot of these barriers, particularly around access, are really policy change and aligning billing with our intent. So, you know, for many providers, being able to cover their cost is really important. So it's great that we want to say, well, you have to better collaborate with medical providers to make sure that all your patients that are going through your alcohol drug treatment services have access to MAT if you don't have an in-house medical provider. But that requires realignment of our policies. It requires realignment of our patient workflow. All of those things incur cost. And so is there also a corresponding billing alignment with that will cover our costs that are associated with doing medications for addiction treatment as part of our service mix? And I think also deregulation of a lot of these things that we've created. So during the pandemic, SAMHSA did reduce the requirement in terms of even this very simple training that providers have to take so that you no longer needed to take this very simple training and you could immediately start prescribing. I think it was still limited though to just 30 patients.
You
30
still have
active.
to apply to get the X
Yeah.
waiver.
But reducing some of these things and realigning our policy to actually reflect our intent of, from a clinical perspective, what we know we need in our various communities.
I just wanted to add a piece to this, which is human service organizations in general access are nonprofits, like most of these treatment centers, right? And in the United States, generally, government does not provide base funding. Typically, they provide service per unit, like unit service funding. That is just for this individual, we pay you $100 per hour for that unit. Generally, they don't say, okay, we're going to support some of your operations at this level. So some of that contracting, you have to have basically all kinds of different contracts to really build your indirect costs, to really fill your indirect costs. That happens more and more with substance use treatment programs that, as I said before, there are 3 to 5 individuals. So there are small treatment organizations. They get these contracts in which they are paid per unit. So, but they are saying, yeah, but we have bills, we have rent, we have this, we have that. Where are we going to get that money to basically run this operation? What I suggest to some county officials is actually to start building some grants for building capacity that really actually go not in the client level, but in other aspects that indirectly support quality of care, which are some making sure that the base, the financial capacity of the program is solid. And this could be loans too. They don't necessarily have to be grants, but they could be loans. But the important part of this, and we've seen it in the data now, is that programs with higher financial capacity, mainly net revenues and some equity revenue, actually are associated with higher retention. It's indirect, but it kind of makes sense. You have more capacity, you have more a steady workforce. That financial capacity makes sure that you are paying those counselors well or adequately. You are keeping them, you're training them, you're keeping the lights on, things are working. That makes sense in a way to me and to our team that creates a little bit more of an environment that is consistent to provide services to clients for mid to long term.
So just to let you guys know, we have 5 minutes left. I know that kind of flew by, but we had a very rich discussion today. I think we covered a lot of different topics, covered a lot of bases. I want to talk about, in closing thoughts for everybody, how you see opioid use disorder treatment or other harm reduction interventions evolving in the future.
I think the public health crisis of overdose is the #1 killer of people under the age of 50 now. Right? Overdose is the #1 killer of people experiencing homelessness. Overdose is the #1 killer of people leaving treatment. Overdose is the #1 killer of people leaving correctional setting. Right? Will prevent any component of our safety net system from ignoring it. And medications for addiction treatment are going to become part of what is expected in a way that is new and is going to put new demands on providers that don't historically see themselves as doing medications for addiction treatment to find some strategy. I also think the county is right now building out a whole number of harm reduction services. It's interesting to say this. You can do medications for addiction treatment in an abstinence-focused model. You can do medications for addiction treatment in a harm reduction model, right? Medications for addiction treatment it's orthogonal to harm reduction, right? I think harm reduction is a strategy of working with people with non-abstinent goals of care. MAT has a role there, but MAT also has a role with sort of like abstinence-focused treatment. And so I think we're going to see the application of medications for addiction treatment in a bunch of settings like correctional settings, hospitals, emergency rooms, treatment programs that haven't historically seen themselves as addiction treatment providers. And I'm excited about that prospect. I think it it's a exciting future to look forward to.
I think one of the components that we haven't talked a lot about, but goes along with the conversation around medications for addiction treatment, is that that is one of our key tools to try to rein in these high number of deaths associated with overdose. Second thing that I'm excited about and that I think we need more of is ensuring that our communities are educated on overdose prevention. That's not just our patient base, but also our provider base, and that they're familiar with naloxone and Narcan products, and make those also available as part of the standard of care for anyone that's going through any level and any type of SUD service. Increasingly, you might not identify as a primary opiate user, you might identify as a meth or stimulant user, but increasingly all substances are being laced with opiates, primarily in the form of fentanyl. And so that having easy access to an overdose prevention kit in the form of Narcan is really critical and important, and that our communities can get those anywhere, not just at county facilities or alcohol drug treatment facilities, but their primary care provider, their mental health provider, that be available in their housing, in their recovery bridge housing and their sober living housing, I think is also going to be important.
I just want to emphasize that for a while, this integration of prevention and treatment has been an idea that hasn't realized.
Mhm.
I think and the United States is not the only one. I think throughout the world, we haven't really figured out ways to mainly structure and finance a process.
Treatment arm, prevention.
Right. It's been separated, as it is separated, mental health and substance abuse still, just very, very separated. But we don't lose the hope that we can kind of integrate and invest a lot more in prevention, especially with what has happened the past few years, right? That prevention is going to be critical. And that is prevention, meaning putting a lot more dollars in communities so they are healthier and that they don't get to deal with the levels of pain necessary or the options with drug markets flooding. The drugs market are going to spread more and they're going to become more legalized, as it has been with marijuana. More research has come out of the CBD and marijuana to try to understand the goods and the bad, not only just saying it's bad, but the goods also in treatment. So I think expanding research on how you use substances to address other substances in preventing is a transfamilial, transgenerational transmission of substance use behaviors from being 5 years old and seeing substance use in your house to later adopting some of these behaviors later in life. I think that's going to be critical. So how the treatment is going to look like, hopefully we don't call it treatment.
Mhm.
Hopefully it's just a continuum, and it's not a system, it's just a community in which treatment is also includes, family interventions and includes web-based access and pharmacy access for all families. And so it's not so regulated, so structured in the way we have.
Yeah. I think every public health problem or issue requires a collective solution. So thank you guys so much for all of the tips and tricks for all of us. I hope we were writing notes. We can all do our part. Yes, of course.
I think we covered socially, medically, policy. And for me, I think change is inevitable,
Mhm.
right? Once educated, you can't go back. Once the red tape has been removed, you can't go back. But I would like to end with a message of hope. As already just in my program, I have seen success with multiple counselors with multiple patients because they come with tools, they come prepped with the education, with the support, medically, psychologically, and through Tarzana, there's all types of services provided. There's detox, there's residential, there's primary care, there's outpatient programs, there's a multitude of support. And if you don't have Medi-Cal, Medicaid insurance, it's okay. Come and we will help you. It's not based on anything other than you just taking that step and walking through the door. So I think that is a big hope for our community, our LA County community. I really see change with hope coming.
Thank you.
Awesome.
That was a really nice place to stop. So please give a hand again to our panelists. Thank you all. Thank you all so much for being here. For those of you who are joining us virtually, your end code is 1031. You'll need this for your evaluation. Again, 1031. 1031. Okay. And you're also going to be required to complete a post test. So you should be receiving a link for that in the chat box. And other than that, you guys are free to go. Thank you so much for being here. This was really fun. And thank you to TTCC for putting this on.
Mm-hmm.
I cannot wait for the next one.
Thank you, Megan.
Of course. Thanks for